So good afternoon, everyone, and welcome to Young and Strong Program's webinar on Positive, which is the study that investigated the safety of pausing hormone therapy to pursue pregnancy after breast cancer. My name is Sarah Damaris, and I am the program coordinator for Young and Strong. Thank you all for joining today. We are absolutely thrilled to be hosting this educational discussion. For those of you who may be new to our community, Young and Strong is the program for young adults with breast cancer at Dana-Farber Cancer Institute. We strive to meet the unique needs of young adults with breast cancer by combating isolation and providing social, emotional, and educational supports, in addition to expert medical care. As always, please use the Q&A function at any time during this discussion to submit any questions that may be on your mind. And it is now my pleasure to introduce to you Young and Strong's founder and director, Dr. Ann Partridge. In addition to being Young and Strong's founder and director, Dr. Partridge is the vice chair of medical oncology at Dana-Farber Cancer Institute, the director of Dana-Farber's Survivorship Program, and a professor of medicine at Harvard Medical School. Thank you for joining us, Dr. Partridge, and I will hand things over to you.
Thank you so much. And we're delighted to have this crowd here with us today. And if for some reason you need to hop off early, this webinar is being recorded, as you probably know, and will be on our website shortly afterwards. So I am thrilled to speak about pregnancy after breast cancer, particularly in light of the recent positive data, with my colleagues and a very special guest today. And without further ado, I'd like to introduce them. If you guys want to turn your cameras on and unmute. First up is Leticia Varella, Dr. Leticia Varella, professor who is here at the Dana-Farber, a breast medical oncologist who has a special expertise in the care and research focused on young women with breast cancer. We'll have her talk a little bit about herself in a few minutes. And then second, and definitely second to no one, otherwise, is Ms. Shayla Johnson, who will tell you her own story and obviously keeping it real, and one of the reasons why we personifies one of the reasons why we developed the positive trial. So first, we're going to talk a little bit about the study itself. We'll talk about generalities, and then we'll dive in to particularly Shayla's story and why this is such an important issue and how people are dealing with it, including people like Shayla. But Leticia, do you want to just introduce yourself a little more and say a little bit about you?
Of course, yes. Thank you so much for having me. I'm so excited to have this discussion. It's such an important topic to all of us. So I am a breast cancer oncologist. So I'm originally from Brazil, and I trained initially there before moving to the United States. And I'm now a breast cancer expert, and I focus all my research in young women with breast cancer. And we work together in several projects. One of them is looking at survival in patients with metastatic disease. And today I'm going to talk a little bit about the data itself from the positive study so that we are all familiar with the results.
Great. And Shayla, do you just want to briefly introduce yourself, and we'll have you tell your whole story in a few minutes, but do you want to just say who you are?
Hello, I am Shayla Johnson, and I am a breast cancer survivor. I've been in remission for 6 years now, and I currently have a 16-month-old rambunctious little boy named Ronan.
Yeah, Ronan's in daycare because Ronan is not, he's not, what do they call it, camera ready.
No, nope. There would be no camera.
That's right. That's right. The toddler, you want to wrap them up in bubble wrap around this time, right?
Yes, 100% yes.
Yeah. All right. So we'll get back to Shayla's story, but let's dive right into positive. Leticia, tell us about this study. Who went into the positive study and why?
Exactly. So just very briefly, just to give an idea about the importance of this topic. So we now have approximately 12,000 patients diagnosed with breast cancer every year in the US that are 40 years old or younger. And obviously fertility is a very important concern among this group of patients. So in the past, we had some concerns that patients that had estrogen receptor positive breast cancers, so the breast cancers that are sensitive to the female hormones, could be at a higher risk of recurrence if they became pregnant. However, more recent data showed that that was not the case, that pregnancy after cancer itself was very safe. But what we didn't know is if we could interrupt endocrine therapy. So for the ones that are not too familiar with that, it's basically the estrogen blockers that we give for prevention of recurrence. So usually women take these drugs for 5 to 10 years, and pregnancy during the treatment is contraindicated. So naturally, fertility decreases with aging. So waiting for 5 to 10 years for completion of therapy would become a problem for fertility. So what the positive study was looking at was, could we safely interrupt endocrine therapy to allow patients to attempt pregnancy? And of course, for patients that desire pregnancy. So the study was a single-arm study. And this was done by the International Breast Cancer Study Group. And it enrolled approximately 500 patients, so 516 patients. And these were patients that were 42 years old or younger and had stage 1 to 3 breast cancers. I will point it out that approximately 93% of them had stage 1 or 2. And then the majority of them had chemotherapy prior to that, and they had to be on endocrine therapy for at least 18 months, so 1.5 years. And they shouldn't be taking for more than 30 months because we wanted to exactly look at this timeline. And these patients were enrolled from 2014 to 2019. So we now have results of the primary analysis of this study. And
Before you dive in, I'm going to interrupt you.
Sure.
Having been a part of the design team, just want to clarify for everyone, why did we do 18 to 30 months? What's magical about that? And I can tell you that it was really because when we were designing the study, patients, and we had patient advocates help us design the study, and their doctors and the researchers, including myself, was very comfortable saying no endocrine therapy. We wanted people to get at least some endocrine therapy because obviously nobody wants a recurrence to happen at all, let alone an early recurrence. And so the compromise, because many people were like, this is crazy, you need to make people take 5 years of endocrine therapy. And we said, that's, kind of I always say, like, a little bit of a jail sentence for some of these women who really want a baby sooner rather than later. And the vast majority are going to be okay from a breast cancer standpoint. So what we compromised on was that 18 months as at least 18 months. And that was in light of data that if you take it for a year, you get about a 10% risk of recurrence, at least from the old tamoxifen studies. If you take it for 2 years, you get about a 30% risk of recurrence. And then 5 years, you get that kind of often quoted 50%. So at least 18 months, at least we were getting some risk reduction. And then the flip side of that, the 30 months was, we didn't want it to be too far out because then it would become, women would be coming in at so many different times. That was number one. And then number two was that it wouldn't be an experiment if we did it too far out, because the standard for people who are coming into me before positive, I would say, well, try and get at least 3 years into you, because that may be getting you close to that 5 years. So if people like Leticia and myself were recommending at least 3 years, then we, felt like we needed to test something that was a little more experimental and that would be more compatible for women, right? Because women wanted often their babies sooner, right? And so that's why we decided it. The one other thing that played into it was not just getting the endocrine therapy into patients for that risk reduction before a pregnancy was attempted, but there are two other really important things. One was to get people through that really early risk of recurrence, the first year or so, when unfortunately sometimes a breast cancer will come back very quickly, even ER positive. And obviously we never want a breast cancer to come back, but the really early ones can be quite difficult to treat. And of course, doing that in the setting of a pregnancy would be really, really tricky. And so that was part of it. And then finally, letting things like chemo wash out of people's systems and all the kind of damage. Not that the damage necessarily fully goes away. It's given with good intentions, obviously, but it was also to get people a little further out from things like chemo and some of the other treatments. So at least that's why we did the 18 to 30 month window. Sorry for interrupting, but I just wanted to clarify where that came from.
Yes, exactly. So yes, so the study did require a washout also of the endocrine therapy. So essentially, if they were taking at least 18 months, they would stop taking endocrine therapy and wait for 3 months to attempt pregnancy. And then the fact that it was a single arm study, it's quite obvious because all these women that were enrolled in the study wanted to get pregnant. So we couldn't really have a group of patients that did not want to get pregnant. But what was done is that the outcomes were compared with big studies that had been done in this patient population. And the two studies are called SOFT and TEXT. And then the outcomes could be compared in a pretty good way. So what was the group looking at essentially? So it was essentially looking at safety as the primary endpoint, or I mean the primary goal of this study. So is it safe to interrupt endocrine therapy after 18, in this interval 18 to 30 months? And what they were looking for was the number of breast cancer events. So in other words, local, regional, or distant recurrence. And now the data that was recently published was the data with a median follow-up of 3.5 years, essentially. So basically, this is the first publication that we have of the data, the primary analysis, but these women continue to be followed. And the incidence of breast cancer events, what they found in 3 years, is that it was about 9%, so 8.9%. And when we look at this control study, so for the women that were in these other studies that I mentioned, it was 9.2%, so essentially the same. And approximately half of these recurrences were distant recurrences, but this was still in numbers, a small number of patients from the 516 patients that had been enrolled. But the study also wanted to look into other endpoints, including
before we talk about that for a second, can we just to clarify, I think importantly, again, we're always trying to prevent breast cancer recurrence. The endocrine therapies are super important, and the positive, the punchline of safety, as you just heard from Dr. Varella, from Leticia, is that it didn't seem that an interruption to attempt a pregnancy. Not everybody got pregnant. She's about to tell you all those numbers, but they did not seem that a temporary interruption of the endocrine therapy had a negative impact on the breast cancer outcomes. It also didn't seem to treat breast cancer, though. It was very similar to what we saw in this age-matched control analysis. So there were recurrences, about 8 to 9%, and about half of them were elsewhere in the body. And the other piece of that I think is really important, and we'll talk a lot about this, I think, in the Q&A as well as back and forth. I think, it was at a median follow-up in the study of about 3 years, a little over 3 years, which was about 5 years on average into women's breast cancer history. So it was a 5-year risk of recurrence, because remember, women couldn't get on the study until they were 18 months into their endocrine therapy. So on average, they were about 2 years into that. And so it's important. It was a 5-year recurrence risk, which was very similar, again, to what was seen in TEXT and SOFT. And the important control groups, we couldn't do a randomized trial where half the women got, randomized to get a baby and half the women didn't, and a coin flip chose that. No one like Shayla or any thinking human being would choose that when you're thinking about a baby, right? But what we did was try and have this control group. But just to, and there were distant recurrences. I think that's the important thing. We're doing a lot of work trying to figure out when those recurrences occurred within kind of the baby parts of it. And there'll be some more analyses that come out. But I think important punchline, no worsening of how women did, at least in the relatively short term, about 5 years out from diagnosis. Again, sorry for interrupting, Leticia. I just wanted to
This is
highlight that.
perfect. Yes, thank you for highlighting. Yes. And I just wanted to finalize by talking a little bit about the other endpoint. So the study also looked into the ability of patients to become pregnant, pregnancy outcomes, birth outcomes, and also breastfeeding, and a couple of other things, for example, resumption of endocrine therapy. So this was one of the things that the authors wanted to make sure that we collected the data on how many of these patients that interrupt pregnancy actually go back on that. And then we're going to discuss that a little bit. So in terms of pregnancy, it was a total of 74% of patients that became pregnant. So this was a total of 507 pregnancies, so quite a good number. And 64% had a live birth, which translates into 365 babies that were born. And in terms of pregnancy complication, which is one of the concerns that patients have, 11% of the ones that became pregnant had pregnancy complications that included hypertension, preeclampsia, and complications like that. And in terms of breastfeeding, it was actually the majority of patients that were able to breastfeed after on the study. So it was approximately 60% of patients that breastfed. And now when we talk about resumption of endocrine therapy, we have a total of 73% patients that resumed endocrine therapy, which means that 27% had not resumed yet. And the majority of these patients that hadn't resumed yet were still trying to get pregnant. So this was one of the reasons why they chose not to resume therapy. So we're going to discuss a little bit of that, but I just wanted to finalize by saying, so the main outcome of this study, which I think is the message that we are both highlighting, is that in the short term, so in this a 3-year data that is actually a 5-year risk of recurrence, there was no increase in breast cancer events for patients that interrupted endocrine therapy to attempt pregnancy. And I think that is the most important final message.
Yeah, and most people got pregnant. But not everybody, and we'll talk about that. And maybe that's when, but the other big thing is, and the babies, and we got good data on the babies. So not only did we get complications of pregnancy, which did not seem to be greater than kind of population-based ones for women on average who were 37 when they enrolled. So it wasn't a young group, it was average age 37, which is kind of, you know, I had my last baby too old, but it's an older mom, a 37-year-old relatively. And then, so the complications for the mothers did not seem to be higher than you would expect in that age group. And then the other really important thing is that complications of babies,
which was just
seem to be higher. There was, yeah, it was good news. So, you know, I think there were a few relatively congenital abnormalities or birth defects, about 2%. And fortunately, those were relatively rare, and no other obvious signals. And our plan is to hopefully follow up on the babies, and Leticia may pursue that as another research opportunity, right?
Exactly.
So let's stop talking about the data. There are some great questions in the Q&A. I will get to those, but first I want Shayla to tell us kind of, you know, why are you on this anyway, Shayla? What is Ronan, and what do you have to do with this study?
Well, I believe that I just fit right into the perfect candidate for this scenario. I was unfortunately 34 when I was diagnosed with stage 2 breast cancer, ductal. So unfortunately for me, I didn't have any children yet at that point. When I was diagnosed, we were actually planning a family at that time. And through other complications, endometriosis since a teenager, I was already having issues in that department. So when I met with Dr. Partridge, one of the first things that we discussed was me having children in the future. So before I went on with any treatment, we thought it was best for me to freeze my embryos. And from there, I went on to have a double mastectomy, about 8 rounds of chemotherapy. And then I was on endocrine therapy for 2 years, a little under 2 years. I couldn't wait to have children. I wanted to be off the medication as soon as allowable. And I went off just under 2 years. I did the washout, and we unfortunately again had to go through several attempts of in vitro, which was interrupted by the lovely COVID situation. So that did complicate things for me just a tad. But after several attempts and just pushing forward, I believe Ronan was round 4 of in vitro, and he came through.
Persistence pays off.
It really, really does. And I get asked, a lot how that ordeal was, and it's kind of grueling, and it's hard as a young woman because you don't have too many people around you that can relate. When people hear of breast cancer, I always make this joke. The first thing anybody ever wanted to tell me when I said that I had breast cancer was, what I should eat. I think everybody thinks they have the magical cure for cancer and they want to give you advice, but nobody ever realizes that each person has a separate journey with breast cancer. And for young women, childbirth is one thing that people tend to forget about. But it was a very huge thing for me to be able to have a child, obviously. But again, he was my 4th attempt. They actually transferred 2 embryos, and he was the one that stuck from the very first ultrasound. I was asked repeatedly if I was sure about my due date. He decided he was coming into this world, and he came in. He came in like a hurricane, all 9 pounds and 11 ounces of him. So, and my pregnancy actually really wasn't that difficult until I got to the end, because he was so big. But I'm definitely blessed with him, but it wasn't easy. And, I find that doing things like this and speaking about my story definitely helped get me through it.
Shayla, thank you.
Yep.
I think, and you participated in the positive trial. So thank you for that, because obviously we now have the data in part thanks to you, so that women can get, the information from positive and help it for them and their families to inform their future decisions. So really, really, really thank you, because you could have done it without us. And I know we bug you to respond to surveys and for particular timing of visits. And anybody else who's out there listening who participated in positive, or anybody who's participating in research, many parts of research are, you do it for you, and you should do it for you, and it should be the right thing for you. But a lot of research is altruistic. It's giving to other people, to future generations, to science, so that we can learn. So we really, really appreciate your participation in this study, as I'm sure everybody on this webinar does, to help us all learn. I just want to pick up on something that you said, and maybe Leticia, you could chime in as well. So, and there's a question in the chat about this too. So, as you guys all heard, Shayla didn't get pregnant magically. She had banked eggs and embryos. I can't remember all that, exactly what you had banked. But it wasn't, easy. And you did go through another cycles of ovarian stimulation. We know from positive that about 43% of women on the study used some sort of assisted reproductive technology. We don't know what yet in terms of when they were on the study, because some people may have banked eggs or embryos and not used them. So they may have banked them before, but not needed them. You obviously needed them, Shayla, and I'm so glad that it worked out with Ronan. How was that for you in terms of your experience? There are not great data about this yet. And so we do worry about hormones and things like that in breast cancer survivors. How did you manage that? And then maybe Leticia, you could chime in on kind of what do we know about that?
How did I manage that in what terms?
Just in terms of your feelings about going into it. And so, when you and I would talk and I'd say, well, we don't have tons of data about this. So what were you thinking about it?
I will say I was a little apprehensive at first. It definitely made me a little nervous. But at the same time, I was very, very determined. For me, directly, I didn't have to continue on with estrogen. I just did the progesterone injections because it wasn't working for me. It wasn't really making any difference. So that kind of helped too, because I didn't need to take it after, I believe, the second cycle. But it does make you a little nervous knowing that that's what your cancer was in the beginning. But I just powered through. The only thing I can say is I just was really determined to have my son, and you guys definitely made me feel more secure about it. And studies like this obviously will help women in the future with their decisions as well.
Thank you. Leticia, how do we think about this when we're counseling our
Yeah.
patients before and now?
Right. So in terms of patients that come to us right after the diagnosis and need chemotherapy, we actually encourage very much fertility preservation, at least to meet with the reproductive specialists to discuss the possibility of saving eggs or embryos prior to chemotherapy, because we know that chemotherapy decreases fertility. And some patients choose to do that even prior to endocrine therapy, exactly because of the timing. And I try to, I have this discussion with every single patient, at least to kind of help them to navigate that. And usually nowadays we are able to do the fertility cycle, the IVF cycle at any moment of the menstrual cycle, which makes things move much faster. So we don't have to wait too long for that. And now, for patients that already had breast cancer and are on endocrine therapy, a lot of them are not able to conceive on their own. And this is why this study is also important, because as you said, like about 40% of patients did receive fertility treatment.
Yeah, and there will be more data coming out about that. And so someone put in the chat, what about IVF? In terms of risk of recurrence, whether getting, as opposed to getting pregnant naturally. And the answer is, we have started to look at it. So far, it looks okay, but we have not formally analyzed it yet. And of course, we did allow it on the study because if women are going to, come off their endocrine therapy, we really wanted them to be able to get pregnant. Like Shayla said, she was determined, and we decided that we needed to study that. It would be inhumane to not let people use the products that they had either, banked before, or to, support them to do what they wanted to do in terms of trying to get to a pregnancy. And then obviously the goal is to get back on the endocrine therapy. The study was about temporary interruption. And that's really important to answer the question, though, of did everybody get back on? As you heard from Leticia, not everybody got back on. The majority have. I don't know if you want to comment on that, Shayla.
I know you've been coming for me for that. I am going to be returning, maybe not. I know for me personally, we discussed just the tamoxifen. I know everybody's story and journey and medical situation is different, but I will be returning. At first we were considering having another child, so that did a delay. Again, COVID caused another delay for us. And now that Ronan is here and healthy, and we're happy with one, he's a lot. So I will be returning. I believe I have an appointment next week to discuss it. So yes.
And there were people on positive who did take a second break to have a second child or didn't go back on. We have not analyzed that yet. The study did not plan on that. We knew that the real world it would happen, and that there would be a minority of patients that wouldn't get back on their endocrine therapy. That actually happens in the real world too, and it happens in even the text and the soft data. where, because we know that some people don't tolerate their endocrine therapy despite best efforts. And so we will look at this in positive, but it's not that big of a study. So it's not clear that we'll actually ever be able to really know, the safety of a second break or not getting back on. But we, for conservative, cautious reasons, given we know endocrine therapy helps, we really wanted people to get back on. So I will, with good intentions and all, I will still harass you, Shayla, because I want you to have the best possible outcomes, and you and I will keep going back and forth on that, I'm sure. But you get it. Leticia, do you want to comment on that?
Yeah, no, I think this is a big challenge, and especially because of the interruption, some of the side effects do go away also. So going back on the endocrine therapy is a challenge, but it is so important. And I think that one of the main things is exactly what you guys are doing, like to keep in touch with your oncologist and just for reassurance and to try to keep everybody on track to go back on the pill. In the study, the maximum that was allowed to interrupt was 2 years to attempt pregnancy, but the issue is like after the pregnancy when to go back, and we as oncologists like seeing that as quick as possible.
Yep, and I've had people use their eggs not because they were infertile necessarily or their embryos, but because they wanted to get back on so quickly. And of course, the how much it might make their outcomes different, if at all, in terms of not getting back on. Not getting back on likely does, but it depends on the risk of the cancer. I mean, that's how we think about this. If you have very low risk cancer, then you're probably not going to make a big difference by a longer break or by not getting back on. Someone with a higher risk cancer, may need more help in terms of risk reduction. That's kind of the way we think about it. We'll talk more about that. There's a bunch of questions in the chat. I'm sorry, in the Q&A. So keep sending them. I'm going to start clipping away at them and then asking Leticia, just so we make sure we answer your questions. So the first one is, does ovarian suppression at the start of chemotherapy count towards the months of endocrine therapy? The answer is yes, it does in the study. So if you got ovarian function suppression through your chemo, then it counted in terms of the time getting to 18 months. Someone also asked about was the 9-ish% risk of recurrence compared to the other group, and it absolutely was. And Leticia, I think, outlined that. The question about, are we resetting the recurrence because it was 44 events and it was just below the safety threshold of 46 events, that was based on patient years of follow-up. Once we got to 1600, we were, statistically, that was our plan to calculate the risk. And when you get further on, the expectation is there would be more events. So it doesn't change the safety threshold unless it goes beyond the threshold that would happen at that time. So you reset the threshold based on the time spent based on those historical controls. Am I saying that? Leticia, do you want to comment on that?
I think this is exactly, this is perfect. That's exactly the case. And this is how it was decided. And it was great to see that it did not cross the previously specified safety threshold.
Yeah, and we're due to reanalyze it again in another, I think 3 or 4 years. So we'll give longer term follow-up, and the expected safety cutoff then would be higher. It would be a greater number of events you'd expect in a control group. So it's not an automatic, if it gets 2 more in the next 2 years, it's become unsafe. As I said it earlier, this is not a treatment for breast cancer, and unfortunately, meaning taking a break and having a pregnancy. So unfortunately, some women will still hear from it again. The hormones dramatically reduce that. And so that's why we want to get people back on and make it a temporary interruption to keep that, risk of reduction low. All right, we addressed the question about IVF and the safety. And we actually did encourage people on the study, if they didn't get pregnant within a year, to see an IVF or a reproductive endocrinologist doctor. I actually recently gave a talk to our reproductive endocrinology community in the US, and they said, are you having people go a little earlier now in light of kind of emerging data? And I said, absolutely. So I've started recommending by 6 months. Positive was a global study, so we had to compromise. What do you do, Leticia, around
I do the same thing. Yes, I would say that in a different situation for a patient that didn't have breast cancer and is not interrupting endocrine therapy, yes, maybe we do wait usually a year. But for my patients, because of this quote unquote urgency to go back on the pill, I usually don't wait too long. So I would say I most likely refer up to 6 months. Yeah.
Okay. There's a question in the chat. Is the suggested time on tamoxifen before a break any less for patients who just receive radiation as opposed to radiation and chemo?
No. So this was the indication for chemo. It depends on the stage and other characteristics of the tumor. So if you didn't get chemotherapy because you did not need chemotherapy, that shouldn't make a difference.
Yeah. And obviously, you know, this is kind of what we studied. People are always going to kind of negotiate to do something maybe different than what we studied. We can't feel as confident about, you know, the risks when someone's doing something different from what we studied. But obviously, you got to talk to your doctors about the pros and the cons of these kinds of approaches. Oh, this is a good one. Were any trial participants initially diagnosed in the postpartum phase of pregnancy? What are the risks of a second pregnancy when the first breast cancer diagnosis was in the postpartum phase? That's a super good question. We're actually looking into that in some other data sets. There were people, so about 75% of people on positive were new pregnancies, nullips, we call that, had never had a baby before. And about 25% therefore had had a baby in the past. And we have not looked at that yet in terms of their outcomes. Do you want to speak to kind of what we know more globally about pregnancy? I mean, I don't think we know it in this context and taking a break.
I don't think we have any specific data about that. What we do know is that the pregnancy itself is not a risk for patients that had a prior diagnosis of breast cancer. So that we have pretty good data showing, but we don't have, like, it would be great to get the you know, a little bit more granular data from the positive study in regards to that.
Yeah, we don't know. You know, pregnant, there's another question about this too. Pregnancy associated as in developed either during or after a breast cancer, and they're a little bit different. During, it's complicated in terms of how we treat people because they're pregnant. After, obviously the baby's out, so it's not as complicated in terms of how we treat people, but there are some data that breast cancer after a pregnancy may be a little higher risk on average in terms of recurrence. We don't truly understand that, but it doesn't mean, you know, and they, you know, we tend to treat towards the patient preference and the tumor and stage and what the tumor's like under the microscope. And we don't know the answer to the question of whether a second pregnancy in a person who developed a breast cancer might impact on their outcomes. We really don't know that. But again, there were, you know, 25% of people in positive had that experience. So it, well, at least total went into it with a prior kid. We don't know that they all got pregnant, but we can look at that. And it will be something to look at. Although again, the numbers may get small and it'll be a secondary analysis. It is a good question that we do think about, worry a little bit about. All right, there's other questions here. There's a comment on having another positive participant sharing their story. We appreciate that. And Shayla, thank you so much for sharing your story. This is a plug for our Young Women's Forum in the fall, where we will have a live patients supporting other patients. Stay tuned, and we'll make sure that we have some people hopefully who are there who participated in positive, so people can talk about that particular issue again. So another person's bringing up that they're being recommended to take 10 years of tamoxifen, and they want to pause again. So that's the pausing again question, and that really is a personal decision. We don't have any great data on that. You know, Leticia, how would you think about that?
Yeah, I do have some patients that we have done that for, like, a very deep discussions and then personal decisions to do that. And but it's not data from any studies or clinical trials, but that does come up because some of them are trying the first pregnancy at a time that then they want a second one. And I have interrupted for some of the patients that decided to do so. And then that's what we try. We try just to, especially with amoxicillin, because of the risk of which is very small risk, but it does exist, of blood clots. We usually wait just for the postpartum time where they are more propense to have a blood clot, and then we resume the therapy. But it's it does come up in real life.
Yeah, we don't have great data around the safety of that second one, but I would say again, when Leticia and I think about it, and the other doctors that take care of breast cancer patients, we think about generally the risk of the cancer to begin with. And if you had a high risk cancer, we are not as comfortable because there's still a lot of risk hanging around. A lower risk cancer, there's not as much risk to begin with, and the risk over time is also, going to remain low on average. And so and we help you to make the best decision for you, recognizing, if you want a second kid, then you have to think about the context of, how much endocrine did you get? How high a risk do you have? What are the other factors that matter to you and around your risk? Another good question, should we get a full body CT or PET scan or other scans before trying to pause to have a baby? Leticia, do you want to answer what we did?
Sure. So in general, just for everybody, in general, we do not do scans to follow up breast cancer patients. And that is based on studies that show that it was not beneficial to do scans, and differently from other cancers like lymphoma, lung cancer, where you do get periodic scans. We don't do that for patients with breast cancer. There is a lot of discussion in the community now that we are getting a little more comfortable with these interruptions, if we should do that before pregnancy, just because this is a group that is a little bit different from what we had in the past, because of the complications of being diagnosed with a recurrence during pregnancy would be different. But we don't have really good data to suggest one way or the other. So this is still kind of up in the air how we are going to all approach. And it will for sure, regardless of how clinicians decide to do it, will depend on the risk of recurrence of the initial cancer.
Yeah, the vast majority of people, though, I'm positive, did not do this. It was not recommended. It wasn't required. And I know that I rarely did it. And I put a lot of people on. I think, I talk to people about it, or certainly if someone has symptoms, we'll do scans, but it wasn't, and when we're not doing that standard of care, then we typically wouldn't do it unless a person was particularly concerned or had very high risk and we were really worried about something going on. All right, I think we addressed this, but did many of the participants develop a new breast cancer after their pregnancy? What's the risk of new breast cancer developing after pregnancy and ER positive disease in particular? And I think the answer is those 44 events total included both local events, which include a new primary breast cancer or a local recurrence of the same breast cancer, or a distant event. And then half of those 44 were distant. So the other half, which was only 22 at the time of over 500 women, were either a new primary or a local recurrence. So yes, some people did have those events. Fortunately, it was only a minority of patients. It happens. And of course, we do recommend people still undergo screening with mammography and sometimes additional imaging of residual breast tissue if you keep your breasts. I don't know if you want to comment on that, Leticia.
Yeah, that's exactly right. Yeah, so this is what we found in the study.
All right. So, this is another good one. I love all these questions. Thank you, guys.
They're very good.
For those that had a distant recurrence, was there any correlation with the initial diagnosis stage or other aspects of their diagnosis? And the answer is absolutely, there was. So the same things that predicted risk of recurrence in text and soft and the greater world also predicted risk of recurrence in positive, namely the things we were able to look at, which was tumor size, bigger tumors, no more nodal involvement, and grade of the tumor. Everybody had ER positive disease. So it was, as I said, it's not, the risk doesn't go away. It's just that it didn't seem to increase the risk, at least in short-term follow-up. All right, there are so many questions here that we may not get to them all. And I think, Shayla, do you want to comment on, were all these questions coming up in your head when you were trying to decide about participation in the trial? And were you focused on the specifics around it, or was it really, how can I get to Ronan?
It was a little bit of both. I did see something pop up. I didn't see the whole question, or in the chat, somebody mentioned the BRCA gene. Just so you know, I do have the BRCA2 gene. So genetically, I was, I can't find my words right now. But yes, I do have the BRCA2 gene. So that was a little bit of an issue for me when having Ronan. I think I was a little more fearful of that than anything else in passing on the gene. That was a big issue for me. But no, I believe I had the same questions that everybody else did. And in the end, I just went on with what was best for me, and obviously your suggestions as well. And yeah, and I also had a double mastectomy. So again, I think I was a little more confident in my choices in removing my breast tissue completely. I know that's not the case for everybody, but it sadly made me a little more secure, ironically. So that was the case with that.
Yeah, I thank you, Shayla. I obviously was going to not share that unless you shared it, because it's your business. But I think that does bring up, when people harbor a known hereditary predisposition, it brings up even another whole level of concerns and questions about, the ovaries and the timing of the ovaries, as well as passing on potential predisposition to cancer. So, and then of course, the risks of new primary cancer are different. The risk of recurrence or either local or distant, we do not think are any worse in mutation carriers, fortunately. But there is a higher risk of a new primary cancer in particular.
And I just comment on one single question that I wanted to make sure that we talk very briefly. There is a question here saying what advice we have for the patients that hear these things, saying, I can't believe you would even consider a pregnancy after a diagnosis and you already have a child, and so many statements that I can think of that my patients are bombarded with. And I wish I had a perfect answer for that statement. But one thing that I do want to say is that this is one of probably the most personal decisions that a woman can face during their lives. So it's really nobody's business to decide for you. So I do think that as doctors, our role is to inform patients the best we can about worst case scenarios, risk, and etc. And we do a good job with doing that during our visits and all of that, but not for the other people to try to make that decision for you. It's really not the right way to go here.
I couldn't agree more. I so appreciate that you said that. And I think this is something for people to discuss with their doctors, with their loved ones. And I think, my often flip response to that is, when I hear that someone's doctor says, well, you already have one, I look at them and say, I'm a second child. I really resent that. No, but I think, how can somebody, that's just clueless and not nice, and not really appreciating what, people's expectations in life and what they want. And I just want to touch on another issue that I think, and we'll answer all the questions after this. We can put it, Sarah will help, and we'll put it into, and I forget how you do it, Sarah. Maybe when you come on, you can say what you do to help with when we don't get to all the questions. But one big picture issue is just tagging on to what Leticia said, and maybe you can chime in, Shayla. There are so many losses here that people have to go through when they're diagnosed with breast cancer, especially at a young age. Just the loss of kind of innocence, the idea that you can kind of be just living your life and then get hit by this, this medical diagnosis that has so many impacts. And obviously fertility for people who have not completed or are interested in future babies and having a biologic child is such a profound and deeply personal thing. And the flip side of the positive study is that some women didn't get pregnant, right? And some women couldn't participate in positive, and some women couldn't bang eggs and can't, for reasons in their lives that may or may not be related to their breast cancer, want babies and can't do it for different reasons. And so I think part of our job as doctors and people caring for people going through something hard is to help make sure that potential loss is addressed. I know you and I have discussed this, Leticia, no matter what stage of disease someone has, even women living with metastatic disease, where no, we're never going to be comfortable with a person living with metastatic disease, with very, very rare exception coming off therapy. There are exceptions to try and have a pregnancy. On the flip side, it's not about my comfort. It's about a woman's life and us helping to support that woman to either, grieve those losses and air them and get help for that, or make decisions that are right for her. I don't know, Leticia.
I 100% agree. Yeah.
And Shayla, I know you had outstanding medical care, but I'm sure there were times when it felt like I didn't get it either, right? And just because I'm on the other side and saying, take this poison, it's well-intentioned, and yes, you need these hormonal things. Do you want to comment on your perspective as, recognizing you're one of a number of patients tuning in today?
And I'm not just saying this because, you can see me right now, but I pretty much trusted your care. I didn't find too much you told me I needed to debate with. You always said things straightforward and, showed me the stats and told me the risk and kind of still let me make my own decision in the end. But you're right. It is very, these are all very difficult decisions. There's no black and white. The gray area is so huge and it's hard from beginning to end. And, I know you said a moment ago, people can be invasive. They don't really know what you're actually going through. And they have a lot of opinions about different things, but, just speak to who you can trust and speak to your doctors, and also make sure you have a doctor that you trust. That's huge. But yeah, none of it's easy. And that's all there is to it. There's no way to give you a spoonful of sugar with that one. It's just a fact. And that's really all I could say about that. You just have to do what's best for you.
I think we got to drop the mic there. Shayla, thank you. Just profound thanks for sharing your story with us and for being so altruistic and brave through all of this. And thank God for little Ronan, right? Keeping you busy and on your toes. I'm glad it worked out. Leticia, thank you for your wisdom and expertise. I'm sure that your referrals are going to go through the roof for positive babies. And now that we have these data, and
to have them.
and we will answer the rest of the questions. And Sarah Desmarais, our host, is going to come back on and do a little housekeeping. But Sarah, can you tell us how we might help to answer the questions and get them out there, because we couldn't get to them?
Absolutely. I will pull all the unanswered questions on the back end, and I will have Dr. Partridge and Dr. Varella answer them. And then when we post the recording on both our website and through our monthly e-newsletters, in addition to the recording link, I will have that PDF file with all of the questions answered there as well. If you do not currently receive our email newsletters, Laura, our wonderful coordinator for the BOC, who's helping us on the back end today, will put that link in the chat. So please feel free to do that, and we will send it out to you as soon as possible. But thank you all for joining today, and I hope you enjoy the rest of your evening. Or
and there's
afternoon.
a survey. There's a survey, right?
Yes. And when we do sign off, there will be a survey that pops up. And we would greatly appreciate any feedback that you have for us.
You fill out the survey, we get feedback, and we try and address it and fix what we did wrong or make things better. So again, Shayla, Leticia, Sarah, thank you all, and take care, everybody.
Thank you.
Thank you.